We're now going on to think about the work of ophthalmic fellows, and I'm very delighted that we've got Luis García Aruba representing Spain for this talk, and he's going to talk to us about the challenges of anterior segment ocular emergencies. I think probably corneas are one of the most frightening things to see in casualty and often very demanding. So thank you, Luis.
Hi, my name is Luis García Onrubia, and first of all, I wanted to thank the European Society of Ophthalmology for the invitation to be part of this series of webinars. Currently, I'm doing a cataract and corneal fellow at St. Thomas Hospital, and today I will try to summarize my personal experience around corneal pathology in the emergency room. We must bear in mind that in hospital-based emergencies, ophthalmological emergencies are a significant component. Conditions related to the ocular surface comprise up to 45% of the ocular emergencies. They encompass a very broad group of pathologies. Therefore, we cannot go through all of the pathologies in just 12 minutes. So I have selected those that are more frequent. We will start with corneal foreign bodies that are the second most common form of ocular trauma, which with corneal abrasions being the number one. Although the cause of corneal foreign bodies is very wide, there are two that personally make me alert. The first one, when the patient has been hammering, since particles released during this activity have a higher temperature and a greater inertia than in other activities such as polishing. Therefore, the risk of having a self-sealing wound that can get unnoticed during the examination, if we are not aware, is very high. For instance, in this case, they found an intraocular foreign body that was missed during the first examination. The second one is when patients who has been driving or walking notice something going on their eyes. I have seen some crazy cases during my training time in Spain. For instance, in my third year as a trainee, I saw a patient who was taking a walk in a bike and noticed that a leaf came to his eye. He ended up with a fungal infection. I think that all of us know that a thorough and meticulous slit lamp examination is needed. You have to write down all the details, the positive and negative signs, explore the fornices, and to be sure that the serial is negative. At any point, if we found any sign of possible intraocular foreign body, a dilated fundoscopy exam and a CT image should be mandatory. The treatment, as all we know, pain control, remove the foreign body, and prophylactic antibiotics. Now we will talk about the chemical burns, which are one of the most frequent causes of occupational accidents. It's important to know that most of them could be prevented with the use of protective glasses. So labor education should be one of our weapons to combat this pathology. Although in recent years, a change has been detected in the pattern of presentation, with a significant increase in assault-related chemical burns. Men are more frequently affected than women. And something that I would like to point out is the chemical burns in children that are frequently related to household cleaning agents, and most of them could be prevented. The caustications can be caused by acids or alkalis. The acid caustications are less frequent and produce more limited damage, being the most common one the sulfuric acid. However, some acids have a high capacity to generate serious damage, such as the hydrofluoric acid, which is an agent used in several industries and has a extreme ability to penetrate into the anterior chamber. On the other hand, the alkaline substances are the most common cause of chemical burn, with a higher capacity of creating a severe damage in the eye. Of note, ammonia has the fastest penetration rate and a high capacity of perforating the cornea. There are two main classifications, the Roper Hall and the DUA. The Roper Hall classification is an important classification system of accurate prognosis, being simple to follow and used in several clinical trials. A weakness of this classification system is that it doesn't take into consideration the conjunctival injury, which has been shown to be of value in predicting prognosis for corneal melting and symblepharon. The other classification, the DUA, has been developed to enable more accurate stratification prognosis, particularly for severe injuries. A key difference between one and the other is that the Roper Hall classification relies on the presence of perilimbal ischemia to assess the limbal stem cell injury, while the DUA requires the presence of fluorescein staining on the limbal area. I think that we all know that the first thing to do facing an eye caustication is to irrigate and clean, taking a special consideration in removing all the material from the fornices. The goal of the acute treatment is to stop the inflammation, halt the epithelial and stromal breakdown, and promote the epithelialization and stromal healing. One of the main problems of the chemical burns is how to manage the late and chronic complications, such as chronic epithelial defects, glaucoma, limbal cell deficiency, and so on. With this purpose, different strategies have been tried, such as the use of autologous serum or amniotic membranes for the acute management. But sometimes, despite of all of our efforts, the limbal cell transplantation or even corneal transplant may be necessary. Now we are going to talk about microbial keratitis, which can be one of the most frequent conditions seen on eye casualty and represent a real diagnostic and therapeutic challenge due to the wide range of organisms that can produce this pathology with very similar presentations. It's more prevalent in patients with altered ocular surface or who present some additive risk factors, such as the use of contact lenses. It is important to highlight the use of contact lenses as one of the biggest risk factors. In addition, the cause of this pathology will vary depending on the characteristics of the population that we attend. So patients with contact lens wear are more prone to bacterial infections. Patients with high-risk professions such as farming or agriculture, they are prone to have fungal infections. What are the risk factors? So epithelial defect, as all we know, is a risk factor for microbial keratitis. Contact lens wearer, we cannot forget about asking the patient, are you a contact lens wearer? It's something very important. Ocular trauma, we cannot forget that surgery is an ocular trauma. Even refractive surgeries are ocular trauma. Systemic conditions, such as pemphigoid, for instance. Ocular surface disease. I have seen several patients during the last month with descompensated cornea due to complicated cataract or fused dystrophy who come to clinic with microbial keratitis. The clinical history is going to be one of our main tools. It's important, for instance, if we see a patient with a hyperacute microbial keratitis to think about Neisseria gonorrhea as a possible cause. In patients with normal epithelium, Pseudomonas or pneumococcus could be the cause. Ask about the contact lenses, ask about co-ocular traumas or any ocular surface conditions should be taken into consideration. It's very important to write down all the details of the slit lamp examination. What is the cornea? How is the cornea? What is the epithelial defect? Are there fibrin? There is hypopyon. And it's important to do as well at the end of the scrape. Don't forget about the corneal sensitivity. It's going to give us information about possible herpes. And one of the big question is when to do the corneal scrape. We had a chat yesterday with one of my consultants about this topic, and we ended up agreeing that a corneal scrape should be made as long as there was no very good reason not to do it. So in my opinion, and after my experience in the last months, we should always make a scrape in exceptional cases. Antibiotics. We have a full range of antibiotics, and one of the biggest questions is if the use of monotherapy or combined therapy as the first line treatment. In this study, they investigated what is done in real cases, being the combination of vancomycin and tobramycin and the monotherapy with a fluoroquinolone, the two main strategies. Daily, for microbial keratitis, I usually use fluoroquinolone as a first line treatment. Another topic is the use of anticollagenasses such as the doxycycline, which can be used in corneal melting. Last but not least, the use of corticosteroids has been a matter of controversy. As a rule of thumb, I will not recommend use them on eye casualty, and I think previous using them, we have to have a discussion with the corneal service. But be cautious, bacteria are not alone. There are another microorganisms such as Acantamia, fungus, herpes, or mycobacteria that could mimic or could be the cause of microbial keratitis. Acantamia was first described in 1974. There was a sudden increase in the number of cases due to contact lens wearers in 1984. As all we know, they are related with contact lens, but as well with ocular trauma with exposure to soil or contaminated water, and people with chronic use of steroids. The main problem with this pathology is the clinical signs mimic other pathologies. I would like to point out the perineural infiltrate as one of our red flags to think about Acantamia. So if we have a patient with contact lens keratitis and a lot of pain that doesn't correlate with the clinical signs, consider yourself warned that could be Acantamia. The treatment course of Acantamia is often long and challenging, and recently more therapy with PHMB has been shown to be as effective as combination therapies. The use of steroids in the treatment of Acantamia remains controversial and should, in general, be used with extreme caution. I think that not in my casualty, and it has to be discussed with the corneal service. Another main thing is to know what is the best dose of PHMB. Several studies are now in process to find out that question. Regarding fungal keratitis, we have to know that this is an important cause of blindness, being more frequent in tropical and subtropical areas. It's mainly related to plant trauma in these locations. However, in our population, it's more related with the prolonged use of ocular corticosteroids or in contact lens wearer. All we know, all the risk factors about fungal keratitis and the clinical signs. One of the signs that I would like to point out is the satellite lesions. This is one of my first cases as a trainee when I think it was my first on call of this keratitis. We did a scrape with the a confocal microscopy, and we found out that there was a fungus. She ended up with a corneal transplant. The diagnosis is very important to have in mind the clinical signs. The confocal microscopy could help us during the diagnosis, but the corneal scrape and corneal biopsy is our gold standard. Regarding the treatment, we have a wide range of options. Prior to the development of natamycin, the most commonly used antifungal was amphotericin B, which is still used today alone or in combination with natamycin, with relatively good results. One of the last studies, the mycotic ulcer treatment trial, found significantly better visual acuity at 3 months in patients with randomized to receive topical natamycin compared with those randomized to receive topical voriconazole. So natamycin could be one of our first-line treatment in infections by Fusarium or Aspergillus. And last but not least, I would like to show a video of a corneal perforation where the use of corneal glue was very helpful. It is something that we are not used to doing every day, but that can be helpful in emergency situations. This can be performed in the slit lamp and under topical anesthesia using a needle to debride the epithelium and draw the perforation, and an absorbent microsurgical sponge to dry the area in which we are going to apply the glue. As we can see in the video, we dry the target area, and now we can use the glue. Thank you so much for your attention. And if you have any questions, just let me know.
Well, thank Lewis for that very useful talk with rather beautiful pictures and videos. Unfortunately, he is really living the life of A&E emergencies, and I'm afraid he's just being called away because he's on call. So I'm very happy that Seema will step in and answer any questions. It seems that most corneal things really do need to see a consultant. Do you think that's true, Seema?
I think it depends on the level of training of your junior doctors in casualty. I think one of the things I feel is really important is, for example, I'm sure every unit will have their protocols, you know, what to do when you see X, Y, and Z. So one of the things, for example, as Lewis was saying, if you have somebody who comes into casualty and they have a lesion that looks like herpes simplex, you know, they've got a dendrite. And if you've never asked the question, are you a contact lens wearer? You'll never think about Acantamia as something to worry about. So initially, I think it's the training and basically the nurturing of your multidisciplinary team. You know, once you've got that in place, of course, if there are things that they cannot deal with, then you have your senior doctors to come and help you. And I think one of the biggest things I would say to everybody who works in a casualty department, be humble, be ready to ask anybody that you think will help you deliver good care to your patient.
Excellent, thank you. Just one question from me. Lewis alluded to chemical burns in children. Now, are there any particular signs that I should look out to see if this is a safeguarding issue, or is it always a safeguarding issue, or are there key things that I should think about when I see children with chemical burns attend?
Excellent question, Liz. I think that, again, here, the history is very important, because sometimes you get injuries that are actually agreeing with the history, but there may be times you'll see clinical signs that don't actually go with the history. And I also think, depending on the age of the child, the body language between the carers, the parents, and the children. And I know that we are ophthalmologists and we deal above, you know, as they say, above the belt. But I think one really needs to, if you're worried, I think if you have the slightest bit of doubt that this is a safeguarding issue, you must contact your safeguarding team, and you must take every opportunity to look at the child's body. For example, are there bruises? Are there cigarette burns? I mean, one's seen horrible things, and one must be alert, and one must seek help. Very good question. Very, very good question.
Thank you, Seema.